Good morning. Okay, just like got it on your screen.
Well, good morning, all. Thank you for stopping in. And the topic might be sort of a misnomer. It's early in the morning, and renal stuff is kind of boring enough on its own. We'll try to speed through the first part of the talk. And the reason it's selected is sort of a limited amount of time. So there's some other areas that we could talk about in the future, but we're not going to look at transplant, for example. We're not going to look at things like cardiorenal syndrome, which is sort of a talk in itself. But what I wanted to do is at about 10,000 feet, look at both chronic kidney disease, acute kidney injury, maybe a closer look at diuretic use, and a closer flyby at contrast nephropathy today. But in order to speak about those, I wanted to spend about 10 minutes just reviewing some renal physiology. So again, not to get too basic, the kidney has a lot of hats. Things from regulating osmotic pressure to the majority of the electrolytes in our body, acid-base balance. It significantly controls the extracellular fluid compartment, and also blood pressure, along with eliminating waste products. The major ones, the end of the protein metabolism change, urea and purine metabolism, uric acid, and creatinine, which we're familiar with, the end product of muscle metabolism. It also removes multiple drugs, toxic compounds, and it also produces several hormones, including renin and erythropoietin, and an enzyme that converts the cocalciferol vitamin D vitamins into more active forms of vitamin D. So, just to bring us back a little bit, the outer cortex of the kidney is the location of where all the glomeruli lie, and it's also richly vascular. If you look at an echo, which I did not put up, I apologize. The cortex is about half a centimeter thick. And in a normal kidney, if we go back to ultrasound 101, anything that a sound beam bounces back at, like it hits bone or hits a calcium, or if it hits any type of scar tissue, you get a white appearance on the screen. And if it goes right through it like water, it should be black. So in a healthy kidney, the cortex should look kind of like the liver, it's sort of mostly grayish. And in someone that has like chronic kidney disease for 15 years, the cortex will be white, be like a big rim, because it's all scar tissue. And it also shrinks. So instead of having a nice thick capsule, you have a little thin wisp of imagination of a cortex. And the anatomy is such that we'll go to in a second, is the loops or the tubules head towards the hilum, and they're all in array. And there's about 1 million per kidney. So the functional unit, again, is the nephron. And what happens at the renal corpuscle is where the Bowman's capsule and all the little tufts are, and the afferent and efferent arterioles. That's where the filtration really occurs. And the rest of the tubules, like the long tube, is where all the actions of reabsorption and secretion occur. So if we put this in line then, and again from the top being the cortex heading in towards the medulla or the center of the kidney, these are all in series. And some of our nephrons have short segments or sharp loops, and other ones have deeper loops, and they go deeper into the medulla. And it has to do with concentration, but that's for a different discussion. I just want to pay your attention on this slide to number 7. Number 7 is the location of the juxtalunar apparatus, and that's where the macula densa lies. And we're going to speak about that in a second. That is a feedback mechanism which helps control blood flow through the kidney. Okay, so how do we make urine? We have blood that comes into the kidney, and it goes by afferent arterioles into these little tufts, and ultrafiltration is made, and we'll explain how that happens in a second. The fluid comes out of the blood as ultrafiltrate, or early forms of urine, and then it flows into the tubular lumen. As it goes through the lumen and to the final, to mix it to the bladder, there's a lot of processes that occur. There's reabsorption, where things are put it out of the tubular urine and back into the blood, and secretion, which is the other direction. And by the time we get to the bladder, most of everything is reabsorbed, and what we end up with is just waste products and a little bit of fluid. Most of these processes, going back to cell physiology, most of them depend on some sort of energy. They're active transport mechanisms, some passive mechanisms, there's some other mechanisms, but most of the transporters need some sort of energy, and that becomes important as well. So the kidneys, healthy kidneys, will filter about 180 liters of filtrate a day. And we make about, average person makes about 1.8 liters of urine. So it's a pretty impressive job of reabsorption along that tube. Now to do that, kidney uses about 20% of the ATP at rest that the body makes, which is a huge energy supply. One solute in particular, sodium, because it has to do with water balance, we want to talk about, and also bicarbonate because of acid-base balance. Most of that happens in the proximal tubule. And then in the loop of canal, we have those, there's a thin descending limb, there's a thick ascending limb. Well, about 25% of sodium chloride gets reabsorbed in the loop. That's why we use loop diuretics. In the distal duct, the remaining bicarbonate, a little bit of sodium, about 5% of sodium. Okay, so if we're trying to get stuff out of the kidney, again, we're talking about excretion. It's basically the sum of what gets, what substance gets filtered into the urine, the tubule, minus what gets reabsorbed and secreted. And if you want to look at that in terms of the renal concept of renal clearance, it's what volume of plasma and under what unit of time does it take to do that. So we come up with the glomerular filtration rate, which is the rate at which plasma is filtered through the glomeruli to start this whole process off. Okay, the classic way of doing that is with inulin. So if you're trying to find a substance that's perfect, if you're trying to measure as a perfect substance to what can be cleared, you want something that's inert, basically, it's not going to interact with anything else. And then it's freely, it only gets out of the body through the glomeruli. Inulin is one of those things you can do. And to do it correctly, you also have to collect urine usually for 24 hours. So it's not very practical. So if someone comes in the emergency room and you're trying to figure out what the kidney function is, you can't give them a jug and say, come back in 24 hours, right? So that doesn't work. So the reason why we look at creatinine, it's cheap to measure. It's the end product of muscle metabolism. There's a couple of down points to it. Some of it is secreted into the tubule, not a lot, but a little, so it's not 100%. But if you look at serum creatinine and you match it for age and weight, you can get an inverse relationship. Hence, whatever the serum creatinine gives us an idea of what the GFR will be. There are some big exceptions to that rule. And I guess one of the things I like to look at in my language is not to use serum creatinine, but to say what's the estimated GFR. I think it's more meaningful clinically. So let's take a look at what are the things that can mess up looking at serum creatinine. It has to be in steady state conditions. It takes a little bit of time for a change in GFR to produce a change in serum creatinine. And also, it's influenced by muscle mass. It's also influenced by, there's a difference between the sexes and also by age. And also there are some drugs that inhibit the tubular secretion of creatinine. So things like Bactrim. Bactrim can be dangerous to the kidney at high enough doses, but even a little bit of Bactrim will inhibit the secretion of creatinine back into the tubule. So the creatinine will go up a little bit. It doesn't mean your kidney function and GFR is disturbed. So the cautions looking at, so these are different equations you can use to estimate GFR. The two most common ones would be the Cockcroft-Gault and the MDRD, which is the modification diet renal disease study, which did not include people that had sick kidneys, by the way, old people. So it's amazing that we use these calculations to estimate GFR. But I think the example here, if we look at Bob, who's a 6 foot, 25-year-old, 300-pound college football player, and his creatinine is 1.3, and we're looking through his chart quickly, we say, okay, that comes out to a GFR about 167. And in the next room, there's one of our patients is Betty, who's 4'10". She's 78 years old, and she weighs 96 pounds. Well, her creatinine at 1.3 gives you a GFR of 25.
Wow, that's a big change.
That is a huge change. So if you first look at the 1.3, and the reason I like to use GFR is because that immediately makes you think of, if either one of these patients had an infection, I was going to think of an antibiotic. If I saw the 1.3, I don't really get too excited. If I see the GFR of 25, I say we probably have to not use the regular dose. Yes?
The GFR estimation that's in EPIC, is that pretty accurate?
It is, but again, it doesn't follow steady state. So the example being, when we get those little CDI questions,
Yeah.
patient's been in the hospital 12 hours, and someone picked up that their creatinine is now 1.6 and used to be 1.2. They sent me a note saying, "Is this,
Yeah.
you know, do you
Say
agree
it's
with
an
the QT?"
AKI.
And I said, "I don't know." What I don't answer is I can't answer that at this point. And that's the danger of that. Is you just look at a number and you're not sure what the baseline is, you can go down a bad track. Pathway.
Thank you.
So how do we assess it? Again, the GFR, normal is about 125. So if you have normal kidneys, that makes about 180 liters of filtrate a day. And that gets the plasma volume in our circular tree is about 3, plasma, not all blood, is 3 liters. So that means the entire, all the kidney's doing is seeing what's in the circulation system. It's filtering that about 60 times a day continuously, which I think is kind of an impressive thing to do. What drives it? Goes back to Stalin forces, so you know the pressure inside the capsule versus osmotic pressure against it. That forms the ultrafiltrate. So that's how come usually systolic blood pressure, unless you have something like nephrotic syndrome or some protein malnutrition where you don't have a lot of oncotic pressure, it's usually blood pressure that's going to drive the formation of filtrate. So the GFR essentially becomes the gatekeeper of renal physiology. At one point I didn't mention up earlier, aging is a wonderful thing. I enjoy it. Makes me feel more wise. But one of the things we lose also, after the age of 40, 45, we lose about a cc per year in GFR. So if
Seems excessive.
it does seem excessive. So if you're at 125 when you're 20, and then run, you know, so by the age of 80, you know, you could easily have a GFR that's, you know, close, I can't do the math that quick, 80 or 70. It doesn't mean you have stage 3 chronic kidney disease. It means you've been fortunate enough to live to 85. So there is some decline in renal function. Okay. Oops. So only about 5 more minutes of the real boring stuff, and we'll get to the topics. But I think, to me, the key here in regulating what's happening inside the kidney in terms of all these processes is regulating the GFR, the renal blood flow. So the good question is, why doesn't the GFR change when the blood pressure changes? Why does it always sort of stay within this ballpark? Because we've been designed with the whole mess of systems that will make sure that we keep a constant GFR. So what that means is, I should have had a slide, I apologize, like an S-shaped curve, usually between 80 and 180 millimeters of mercury. It's a pretty wide range. That's systolic pressure. GFR remains relatively constant, doesn't change. You would say, well, if it's 180, there's more blood pressure going through, the rate of fluid for the tubule should be faster. So we should be reabsorbing or losing things quicker. And the reason we need that, because we would, if our blood pressure went up to 160 because we were doing some running, and our GFR increased to 150 or 160 cc's per minute, we're either going to become dehydrated or we're going to have to take more than Gatorade because we're going to start losing more electrolytes. Then on the other hand, if our blood pressure gets too low, we're not going to filter at all. So that's the beauty of this system that keeps a wide range of blood pressure, keeps our GFR going. And another just small point, if we go back to that initial structure with the cortex of the kidney, that neck of the kidney uses about 4 cc's of oxygen per minute per gram of tissue, which is the second highest rate of perfusion in the body, second to the carotid bodies on the neck. So there's a ton of oxygen delivery there. In the cortex or the deep medulla, just the opposite. It's like 0.2 to 1 cc per minute. What does that mean? Well, that's where all those tubules are at. So if you get into low blood pressure or you get into hypoxic states, the area of the kidney that's going to get injured first because of ischemic injury is going to be those tubules. So hence, why do we see acute, ATN, the acute tubular necrosis? Because these cells are not getting enough oxygen to do their job of transporting, so they start to get injured. So that even though the whole organ is getting a ton of oxygen, it's not distributed very well. Okay, so how do we control it? There's two intrinsic ways, which is just a stretch of the arteriole causes a reflex of constriction, which increases GFR. And then there's the tubular feedback, which is not that easy for me to say, TGF. Put an I in there, I guess if you think about it's Friday. And that's where that sliding, that little macula densa sits. That's sort of an autoregulator. It measures the amount of sodium that's coming out of that tubule, and it'll do some things we'll talk about in a second to either speed up flow or decrease flow. There are some intrinsic mechanisms. The sympathetic nervous system has some say, and also the RAS, which I think we should review, and the natriuretic peptide as well. So going back, that little number 7 spot where the afferent arteriole and the distal duct all come together for the same unit, for the same nephron, it's measuring the concentration of sodium chloride as it's coming towards the end of its trip. And it will, depending on the concentration, it will cause vasoconstriction of the in-pipe or the afferent arteriole, which will cause a decrease in the blood flow and hence decrease the GFR back down. Appropriate. So that's one of the mechanisms to keep that blood flow the same. So what happens when we get excited or we get noradrenaline going, which it causes vasoconstriction systemically and also within the kidney itself. So what happens with this? So renin gets released. Okay, renin is one of these hormones the kidney makes, and we're going to might sort of speed this up and go to this. This is a real busy slide, and I apologize. But this, if we look at, it doesn't have to be that complicated. So renin produced by the kidney, and what it does is it cleaves angiotensinogen to angiotensin 1. And then we have that thing called ACE, which is an enzyme which makes angiotensin 2. So the culprit here is angiotensin 2. It has lots of effects. It will stimulate sympathetic nerve activity, which we know will cause constriction and make pressure go up. At the actual site of reabsorption of the tubule, it will increase sodium reabsorption. So remember, water wants to go wherever direction sodium is going. So if we reabsorb sodium, we're going to be obligated to reabsorb water. Both of those are going to increase total volume, extracellular fluid volume, right? It also affects the adrenal gland, so that makes it secrete aldosterone, which has a direct effect on the tubule as well. And angiotensin 2 is also a direct arterial vasodilator.
You really wanted to do this?
And what also happened in the pituitary gland, in the hypothalamus, it causes so it creates increases thirst, and in the posterior pituitary, it increases ADH. Not to get too much into, so normal state of affairs in the distal duct, water is impermeable. So as urine's coming by, it's just going to go right to the bladder. With the influence of ADH, it opens up these aquipores that are usually close to water, and water is then reabsorbed back in. So going back to what ADH does, it makes the low volume urine because it's making water reabsorbed. All of these features of angiotensin 2 either increase blood volume or blood pressure. Okay, and they can be detrimental. They're supposed to be mechanisms to preserve kidney function, but they become detrimental. And then there will be a negative feedback. They'll come back, and then they'll stop. What's the stimulus for stopping renin? Is you get too much fluid. So, okay, we're going to sort of feed through this a bit for the sake of time. Okay, so that's what clinicians, we should get to some clinical significance. the ACE inhibitors, hence, I guess they inhibit the ACE. And what they essentially do, from the kidney point of view, is they decrease angiotensin II levels. What effect does that have? Well, systemically, it will decrease vasoconstriction, so it will reduce blood pressure. It will also reduce sodium reabsorption in the kidney. It will reduce, but this is the interesting kicker. You say, well, how can this, it reduces GFR? It kind of makes sense, right? Because it decreases arterial vasoconstriction, so the force coming into the capsule, that's going to affect renal blood flow. So to a certain degree, what you're going to lose with that is a little bit of filtration, right? Because so you expect the GFR actually to go down a bit, or a certain fraction to go up a little bit, and it can go up about 15%. So that's what when you start someone on an ACE, don't be alarmed. That's another situation. Someone comes from an outside hospital, and they were started on Simple yesterday, and you get the CDI inquiry about, is this an AKI? I have no idea. They were started on like 3 drugs and an NPO, and I can't figure out steady state. So don't bring up AKI to me at this point. The other, from kidney disease, the reason why ACE inhibitors are beloved by the nephrologist is one of the most common forms of kidney disease is diabetic nephropathy. And the process there is that there's a lot of sclerosis that occurs inside Bowman's capsule. And that occurs because of the process of diabetes in combination with high blood pressure. So anything you can do to sort of protect that little tuft of capillaries, so if you can reduce the capsular pressure by reducing the flow into the Bowman's capsule, you're sort of preserving that kidney structure. It's not being pathologically mutated, if you will, as quickly. The price tag for that is you lose a little bit of GFR because, okay, well, what's the difference between a GFR of 35 and 30 if you can make that kidney last another 5 or 10 years? So that's the rationale. You actually, in early diabetes, what you see is hyperfiltration of the nephron. Okay. Chronic kidney disease at 10,000 feet. Roche's definition is if your GFR is decreased for more than 90 consecutive days, irrespective of the cause, you now have a label of chronic kidney disease. So that can be lots of things. And in our population, it's diabetes, hypertension, account for about 70%. Interstitial nephritis is it's a process, it's usually caused by drug. It's an immune process where there's a huge white cell response inside the interstitial kidney. The detection of that is either a decrease, you notice that GFR is decreased. In the urine, you get a sterile pyorrhea. You get like a gazillion white cells, no evidence of infection, and you get white blood cell casts because there's so many casts inside the kidney. Chronic pyelonephritis, all the gluten-free nephropathies, which is lupus and all the post-infectious and all the different nephropathies, which is another talk. Cystic disease, congenital disorders, most of those are from the collection system. Most children with chronic kidney disease is because they have birth defects with the drainage system, and they get a lot of back pressure. Systemic infections, neoplasia, what happens is tumor takes up normal real estate. Every time someone has an acute kidney injury and things get better, we have a 2 million nephrons. Some of those get damaged. So if you keep on having a little AKI every time you come into the hospital and you get diarrhea, over time that adds up and you can have chronic kidney disease. Low birth weight can cause it, and a reduction in kidney mass. So most causes of chronic kidney disease, again, have to do with, the pathology has to do with hypertension inside the glomerular apparatus itself, and/or systemic hypertension, and/or inflammation and fibrosis. These are all of those processes thrive off of activation of the RAS system. So again, the reason why ACE inhibitors are like beloved by the nephrologist is that they do put the brakes on some of these processes. Risk factors for progression. Everyone has a little, as we said, if we're fortunate enough to get old, we're going to have, by definition, decreased kidney function. Nothing to get worried about. What to get worried about if you have high blood pressure, if you're losing protein in the urine, or if you have recent episodes of AKI, they can all be prognostic signs that things might decline quicker than 1 cc per year. Okay, control blood pressure, reduce proteinuria, cardiovascular risk reduction. Stage 4 chronic kidney disease is an independent risk factor for developing cardiovascular disease. So there's another reason from our point of view to try to behave with the kidneys is that it's another risk factor for the stage. So there's lots of, we could probably move SGLT2 inhibitors on the bottom up to a proven benefit now instead of a possible benefit. Reducing sodium and protein amounts, exercise and smoking. I think most people are familiar with the stages of chronic kidney disease. They're actually, they're used more for making predictions. You know, if we look at a Bell distribution of everyone that has chronic kidney disease, there's a huge peak at stage 3. And thank goodness most people don't move on into stage 4 or stage 5, or we'd have dialysis centers at every corner again. But it has to do with, you know, people with stage 2 disease, they really don't need to be seen very frequently, make sure their blood pressure is okay. They're not going to have very many complications. Stage 3 disease is a pretty huge swath of population. And then now there's a tendency to divide this between early 3 and late 3. Because what happens is the other complications of losing kidney function start to show up as you lose GFR. So as you get into late stage 3 disease, you're going to start seeing anemia, you're going to start seeing bone metabolism problems, high levels of PTH, high levels of phosphorus, more restrictive forms of anemia that are going to require treatment. Also, you have to start preparing folks for what they want to do, which is another discussion in itself. So, again, I guess I have a slide. One of the reasons for the staging system is to put patients into silos of what needs to be done and how frequently they need to be seen. A real quick thing with anemia, you know, nowadays, fortunately, we have both venifer and iron preparations as well as erythropoietin stimulating agents. They all have, you know, when Epogen was discovered, everyone went crazy. In the dialysis world, they used to try to bring everyone's hemoglobin almost back to normal. Then they realized that other people were dying and having a lot of heart attacks. So there's an association with overcorrecting anemia in dialysis patients. A lot of people have pre-existing tumors or active tumors where you're sort of feeding the tumor. So it's not, there's a tight window where you want to keep people's hemoglobin in the dialysis low anyway. You also get, excuse me, as we all know, we get WBC function, which is why people, you know, the first people to get boosters to vaccines, or why, you know, is because their immunity is messed up, especially the dialysis population. A lot of these folks are also diabetic, which is another reason. And you'll see this, when people come into a clinic, they have to get hepatitis B vaccine, and a lot of times it won't produce an antibody response. Challenges. Bone disease is another discussion for a long time, but it's kind of important because this is the type of thing that causes morbidity. These are folks that fracture bones pretty quickly, or they have a lot of bone pain, and there are several different types. What happens, again, with late-stage kidney disease is because of extra phosphorus, calcium gets a little bit low, the parathyroid gland doesn't see that, and it just tries to keep calcium up, so it overproduces. So you have very high levels of PTH, which can cause disorders of bone matrix and more easy to fracture. If you overtreat it, you can cause adynamic bone disease. That's when you, and it causes the same thing, causes brittle bones. If you're on dialysis for a long time, you're going to get these depositions, the amyloid of beta-2 proteins, microglobulins, and they will deposit in tissues and cause a problem. And osteoporosis, which is also a big problem in the transplant world, right? So, so at the end of the story, we have a chronic kidney disease. We're trying to keep people in the stage they're at. But there is a time course. If someone that develops an acute kidney injury, like postpartum or whatever, this happens abruptly. There's no time for any planning. And someone that's had diabetes and hypertension for the last 40 years, and you've been seeing them for like the last 15 years, you have a lot of time plan and discuss on what people want to do. So a lot of it has to do from a management point of view. What's the time course of this type of injury? When does someone start dialysis? It's a great question. The textbook says when the GFR is at 15. There's a lot of people walking outside these days that have GFRs at 10 and 12 that are, they're not ready to run a marathon, but they're kind of functional. And starting dialysis isn't going to make them feel any better. Dialysis is a very taxing thing for people. The signs of uremia are very nonspecific. So anorexia, nausea, pruritus, fatigue, edema, insomnia. I would probably say, in the heart failure world anyways, that's probably about 95% of the patients walk in the door, and they're not uremic. So there is one specific. The nausea of uremia is extremely, it's almost like pregnancy. It's nausea early morning hours, and then it goes away, which is sort of a classic uremic symptom. So the decision to start dialysis is basically you can't manage volume, potassium, or metabolic acidosis. That's usually the time. When people start losing weight, people get malnourished, nothing good happens. So those are, and when I worked in nephrology, I was always concerned having these discussions because, like, with someone for a couple of years, and it's like, well, most normal people, I said to myself, Mike, if you want to start dialysis, I say, hell no. But when you get to feel really poorly, people will tell you, I think it's time. And usually that's right. Okay, acute kidney injury at a farther distance. So unlike having a change in kidney function that's greater than 3 months, this is an abrupt change. It is all different. You can pick whichever system you want. There's, I think, 4 or 5. Roughly, it's a combination of a change in serum creatinine and a change in urine production. And the combination is different stages, but that is what acute kidney injury is. And going back to, this is almost like, it's almost like, heart disease, where you have like pre-kidney thing, contractility and half the flow and the volume of the AKIs. Look at the kidney as a second heart or whatever. Pre-renal causes, renal causes, and post-renal causes. Most of the things you see in the hospital are pre-renal, and they have to do with decreased effective circulating volume, low blood pressure, anemia. Things that affect the tumor are direct luminal disorders like lymphopaths, vascular occlusions, tumors. And if you have obstruction to urine flow, that back pressure back on the kidney will upset the GFR. It's just a schematic of the same thing. Sorry for the 3 different systems. You can pick whichever one you want, but basically it's a change over a short amount of time in renal function. It's a search for better markers. How can we pick up AKI earlier? If we have, I don't know who's on, I can't see the screen, but I always like to pick on Dan. So if Dan was on, if we got Dan this morning and we decided to, at 7:30, we took his blood and his creatinine was 0.8. And then we decided we'll put a Foley in Dan and we'll drain his bladder, and then we're going to let someone put a renal artery clamps on both the right and left renal artery. At noontime, how much urine do you think he's going to have? He's going to have no urine because we clamped his renal artery. If we take his blood at noontime, his serum creatinine might be, I don't know, 1.4 maybe, 1.3. Might warrant a CDI query from someone in the hospital. But by tomorrow morning, it's got to be 3. So I mean, the problem with acute kidney injury is being able to pick it up quickly enough. And so that I just went too fast. What are some of the causes? Evil NSAIDs are terrible drugs. They reduce GFR because of their effect on the arterial. They also a big group of drugs that cause acute interstitial nephritis. But the good thing is, if you stop them and you make sure the pressure's okay and they're hydrated, usually kidney function will come back in 3 to 7 days. The drugs that we love, the ACEs and the ARBs, they're great. However, if you're dehydrated or you're hypotensive, they're really bad. They can turn a good thing into a really bad thing. And they're classically known for the post-operative AKI. The reason for that, general anesthesia, if someone gets put to sleep, initially their blood pressure drops like a lead balloon for a few minutes. And anesthesiologists dial in this, dial in, they make the curve look nice, but for the first few minutes of anesthesia, it's pretty severe hypotension. And when someone emerges from general anesthetic, it's just all these nerves awakening, and it's just the opposite effect. People become very hypertensive. So this poor kidney that's trying to keep its little GFR going is getting all messed up. It's getting high signals and low signals. And it's one of the reasons why ACE inhibitors are just kind of rough surgery in general. Gentamicin, which we don't see used as much anymore, but we do see steroids. The antivirals can cause a crystal formation in the tubule, and they can be kind of rough on the kidney. Our old friends cyclosporin and Tacro, it's kind of ironic they used to keep a kidney or a heart from being rejected, but the most common reason why kidneys fail is because of calcineurin inhibitor toxicity over time. So those agents will cause toxicity of the kidney. So you can get large pigment nephropathies, rhabdomyolysis, you get this massive amount of material that overwhelms the kidney to be able to filter and it clogs up things. The shaggy aorta, cholesterol emboli syndrome, you get tons of little cholesterol emboli that block vessels. Radio contrast, we'll talk about in a few minutes, I promise. And TMAs, which can be caused from a lot of things like the hemolytic syndrome and Ebola virus causes a similar type. There's lots of things that can cause TMA. Also, these tumor lysis syndromes. It makes sense. These are usually the hematologic tumors. So someone that gets a big wad of chemotherapy and they have a huge tumor burden that gets lysed quickly, all that material can clog up the kidneys. And hypercalcemia by itself is the direct vasoconstrictor. So if someone's calcium stays like at 14 for like a couple of weeks, that by its lonesome is enough to damage kidneys. Okay, what to do about approach these? Usually, it's for our population, if someone's in the hospital, it's usually multifactorial insults that cause the AKI. It's not just one thing. If someone's coming in to the office, it's usually triggered by something. They took a drug or something like that. How to approach it? Basically, I'm going to switch over to, I only have one of Mike's, several of Mike's pearls, but this is, when you see almost any patient, the questions that I want to know that we should ask, especially with people with kidney disease, is what is their blood pressure? And not only what is their blood pressure now, but what has their blood pressure been in the recent past? I mean, in the hospital, we can look at the EPIC thing and see what's been recorded the last day or two. If people are at home and they have the service with their blood pressure and weight daily, those are really important clues. And when you see it, someone who has a serum creatinine that's jumping all over the place, it's very wavy, that's almost always will reflect people that have blood pressure that does the same thing. What's their volume status, which is always a guess, in my opinion. But that's kind of key. Are they sort of dry or are they wet? And basically, what's their poison exposure? In other words, what medicines have you been giving them? Which I think is sort of key. Because again, going with that, whatever that GFR is, if we think of GFR and not serum creatinine, we should be adjusting medications almost all the time. The other question is that, with acute kidney injury, does someone need dialysis now or not? And what can we reverse here? You want hemodynamic stabilization, roughly those numbers, and you want to optimize volume status. Then you wait. Okay. Oh boy. So to go back to this famous 70-kilogram person that's around somewhere, and we know that a liter of fluid equals a kilogram, and that 60% of our body weight is water. That means that 42 liters of us for 70 kilograms of water. 2/3 is in the intracellular space, 1/3 in the extracellular space. And out of that extracellular space, there's only 1/3 of that, about 4.5 liters, which is in the intravascular space. And that to me is a key concept because that's what the kidney is saying. It's not saying the total body water content. It's saying what's being delivered to it. So what happens when we have ECF volume expansion states? We have things like CHF, hypertension, things you all know, chronic syndrome. You're very familiar with the symptoms and also the signs. So what happens with this, though, is that usually in healthy states, when we're healthy, we have healthy kidneys, when we have an expansion of that volume state, this usually increases the blood pressure and our cardiac output, and we have usually appropriate renal handling of sodium and water. We get rid of it. However, in certain sick states, water and sodium are retained due to this concept of arterial underfilling or low perfusion, and the kidney interprets that as that it's losing too much sodium. It's doing everything that in the world it can do to hold on to sodium. It's sort of an incorrect response to reality. And this is a big problem with both cirrhosis and CHF. So the other way of looking at that, in the circulation field, that 4.5 liters, 85% of the blood is circulating on the venous side, and only 15% is on the high pressure arterial side. And again, the kidney's looking at that 15%. So when you get that expansion of the venous compartment that much, then this is the thing that leads to this arterial underfilling concept. And the response to this, again, is retention. The kidney does not see swollen legs or fluid in the pleural cavity or cirrhosis, ascites, does not see it. So what it's trying to do now is it's trying to save sodium and water, which will just make this worse, right? So how do we go about treating this? Well, you treat the underlying cause. You want to get and achieve a negative sodium balance. I can't say enough about that, but that's sort of like asking someone to stop smoking and to lose 20 pounds. Trying to get sodium reduction is key. Diuretics don't work. If you are taking in a ton of salt, diuretics are not going to work. So the first step is try to get a negative sodium balance by sodium you're taking in. Then you use diuretics. Okay? So again, you folks know this, edema, but why do we form edema? It's the same reason why we have filtration, basically. It's Stalin forces. So what I might do, we've got like about 10 minutes here. We have a kind of a lengthy section on how diuretics work in my class, but that might take a little bit more than 10 minutes. We might jump, if it's okay, to contrast nephropathy, which is a little bit shorter. So it's all right, we'll make this stuff available. Okay. So contrast nephropathy is an interesting thing. It's been around for a while, and I've worked in different areas, and there's always been some great, what can we do to prevent it? And there was all types of trials on using bicarbonate and acetylcysteine and even Lasix, and then hydrate. You hydrate with what percentage of fluoride. And at the end of the day, I think what we've learned is that contrast nephropathy occurs. The exact mechanism people still don't know. It's kind of like an ATN type of thing. That administered after the administration of iodated contrast. It's generally reversible, and it's generally not that common. We see a very skewed population. If you think of the amount of contrast that's being delivered out there. So if you look at in the cardiology world literature, the incidence of PCI, people that are coming in to have their whatever stented, it's only about 3 to 5%. That's not huge. And however, patients that have pre-existing like CKD, a little bit higher, the baseline creatinine is like 4, it's almost like close to a 50% chance. Now, the normal history of this after exposure, what you'll see the creatinine rise, and usually not. They had their calf this afternoon, and we check the creatinine tomorrow morning. You can miss it. It takes sometimes 48, 72 hours for this to show up. It should peak around 3 to 5 days. So if you take a BMP like tomorrow morning or a BMP 2 weeks from now, I might miss the whole event. But anyway, so would increase the risk bar. this is sort of like the, looking at R7 or R9. Pre-existing CKD, heart failure, dehydration, diabetes with renal involvement of any type, high contrast loads, multiple contrast studies within 72 hours. How do we go about protecting people from this? Well, you limit contrast procedures. You hydrate with saline both pre and post. And if you got really bad heart failure, that might not be such a great idea. The other thing to do is maybe hold a diuretic, one or the other. Trying to give someone with an EF of 20 who comes in already expanded 200 cc's an hour before a test is probably not a great idea. If you sort of hold their Lasix drip for 12 hours, that might be helpful. There is no benefit to using sodium bicarbonate at 6 point. And what I wanted to do is, maybe talk about something. A real life story for us would be, someone shows up, we'll pick some from outside hospital, they're a diabetic fellow, and they're short of breath. So they come into the hospital, and they say, "Oh my God, the guy's short of breath." They do all these blood tests, and the D-dimer comes back borderline. So we got to get a CT with contrast. Well, thank God you don't have a pulmonary embolism. But your troponin came back, and it looks like it's positive. So I'm going to call, Dr. Waldy up or someone down here at Maine Medical Center and say, like, I got this patient that now has an NSTEMI, and he has to come down here right away. So we made him NPO because we're going to take him right to the cath lab because we know we process people very quickly. So now we have this diabetic that got some contrast. Used to have a normal, creatinine, and he's coming down here. Jesus, guy's got. He might have NSTEMI, blood pressure is 140 over 90. We should put him on beta blockers, heparin for sure. So now his blood pressure is like 100 over 60. The cardiologist is very happy because the blood pressure is great. We give him some contrast today. We made him NPO all day. Comes tonight at 10 o'clock. Lenny says, "Oh, geez, we can't do it now, but he's going to be first case tomorrow. I'm going to make him NPO. We'll give him a glass of water." Right? So, we just have a patient that was normal. Didn't have any pre-existing reason, and not that it was intentional, but a lot of the patients will be processed, which is why, in this, to me, this highlights steady state conditions. It highlights all the other things that are going on, all of them that can sort of add up to be not a very good thing to do. So my only caution is that I don't think contrast nephropathy is as dangerous a thing as people think. You always want to try to prevent it. But there are certain patients that you can almost guarantee are going to be at much higher risk, and a big chunk of them are the people that we see because of the process that they go through in the immediate history before coming here. So I apologize for not getting to. It's like 5 of, and we all have rounds to go to. But what I wanted to talk about was diuretics a lot, and I can maybe pass out the slides or something. But that's about it. If anyone has any specific questions, I'd be happy to answer.
Thanks, Mike. That was good.
Mike, I have a question.
Sure.
Patty. So if you could clarify to people why we hold ACEs and ARBs in people. Some of us hold them in people who come in with normal kidney function.
Yeah.
Prior to cath.
Yeah.
And I think sometimes there's a preconceived notion that ACEs and ARBs are going to kill the kidneys for whatever reason after contrast exposure. Can you clarify why either with normal kidney function and or with chronic kidney disease, we hold ACEs and ARBs prior to receiving contrast?
If
If they're normal, that would not. If you've got six nephrologists in the room, you're going to get a half a dozen opinions here about.
I know, and that's why I was sort of asking the question because I don't hold them personally if they're the kidney.
I do not. I mean,
but a lot of people do.
You can run into trouble holding an ACE if you have low blood pressure,
Right.
or if they're dehydrated. Okay.
Correct.
Those are the two conditions that could potentially happen if someone's made NPO and you're only giving them 100 hours of fluid because they might be volume expanded. So it depends on the clinical situation. If someone's kind of rickety, it's mostly the stuff that we do, NPO status or preventing people from taking free water in. That is, or general anesthetic. If it's someone's going at 7 o'clock in the morning, I mean, there's also some data that when you stop an ACE, you can mess up kidney function, but well controlled. So it's if someone's coming in and look otherwise healthy and they're going to be done this morning, I do not hold ACEs. I will always hold them for surgery.
Oh, well, yeah, there's data saying that, yeah, because of irretractable hypotension following
Yeah.
anesthesia for surgery. But for caths, I think a lot of us are, there's some misinformation as far as whether or not we need to hold them.
Right. I agree. I mean, I think it's, people get so used to having their smart phrases. So if you get a renal consult, they'll say avoid nephrotoxin, blah, blah, blah. But, ACE inhibitors, as we've shown, can be the same. They can be the killer depending on the clinical situation. Just because they're going to get some contrast exposure, but if they're well hydrated, I would not stop an ACE for that.
Thanks, Mike.
Mike, can I ask you a question as well, please?
I'm sorry about cannulating you, Dan.
No worries. It seems like when we have a patient with heart failure with reduced ejection fraction, as they're about to leave the hospital, there's a race to get them on guideline-directed medical therapies.
Yeah.
And there's often a question around, like, the blood pressure today was 105/60. Yesterday was in the 90s, but we've got a little room today. Let's start that carvedilol at really low dose. You mentioned with CKD a goal of like 120 to 140. Should there be a bigger assessment around cardiorenal syndrome and CKD rather than just jump in to put them on these medications?
That's a really good question. It's an excellent question. And the answer is there's a tension point. And I guess on one side, there's a pressure to put people on, if you don't get them going on medical guided treatment right away, in the real world, what happens, visit 2 weeks, then we start one, and then something else happens. Week 2, we start another. And it seems to take like 4 months to get therapy going. So they try to get it all going before they leave the hospital. But I'm extremely cautious, and I'm always saying, you don't know what the response here is going to be. If you have someone that just had an MI, and all of a sudden they have an EF of 25, these people have had little time to adapt. So those are the folks that I think that are not going to tolerate a blood pressure at 96 at all. If you have someone that's had CHF for a long time, and they've been living with blood pressures in the 90s to 100, those are the ones you can add hydralazine and afterload reduction. You get their pressure, they seem to live okay at 90. I always would check renal function in these folks. But again, I'm dancing around your answer. To me, yeah, that's precisely the population. I mean, the discussion we didn't talk about today was cardiorenal syndrome, which is huge, and it has a lot to do with all these neurohormonal, RAD systems, and they're all cross-talking with each other because one is sensing low blood pressure, one is doing, and it's sort of, we're creating sort of havoc. But we're going by studies, so we're trying to do 2 things. I think we have to proceed cautiously and, to me, prove that they can handle it. If you're going to be doing this therapy, they definitely need like BMPs weekly, and they need to be seen. They can't be seen 4 weeks from now. I mean, they have to be, these folks have to be followed very closely.
And that's, it's Jeannie, the nurse practitioner and outpatient. That's when things seem to not work as well because we try to, it seems like the BMP results, like right after hospitalization, at times tend to get lost, or in other words, that the patient waits 2 weeks and then we realize that the patient's hyperkalemic or didn't tolerate, or their blood pressure is low after a certain event and it gets held, and then the patient waits 4 weeks and we know that he really needs it. And so I feel like we could do a little bit better in that post-discharge communication, and sometimes the labs go back to the hospital peeps, not so much the APPs, because I'll give us credit that I feel like we do better in that aspect. But if they're ordered by attendings or other docs, it tends to go to them and we don't get it. So we don't get really a red flag.
So Jean, this is Patty, just to let you know, the doctors do not order anything on discharge. The doctors have really nothing to do with discharge other than having a conversation with us and what needs to be done. And when we order follow-up labs at discharge, we order the results to go to the patient's primary cardiologist, or if they were a new patient to us, they're supposed to go to the cardiologist who is following up with them. But the cardiologists never order any labs per se. We do all of that work. So if there needs to be a conversation as far as glitches and follow-up stuff, maybe we should get together.
Oh, no, you're, I'm very, very grateful. You know, the ticket is that, you know, we all cover, you know, docs' labs if they're
Sure.
abnormal, so they sit in their bin and, you know, their labs look great. So that's the kind of loophole. It's on our part. And thank you for clarifying that.
Yeah, and if there's anything we can do on our end, I mean, it's really important that the two venues, you know, outpatient and inpatient, communicate. And I think a lot of times the APPs do a lot of the follow-up work and the follow-through work and the discharge work and whatnot. So yeah, let's maybe talk more.
Perfect. And don't let me take away the excellence that you all do as a team. I guess, you know, I think that.
Oh, you did it. No, I just want to
Okay.
make sure we're talking. Yeah.
All right. And I know we're all busy and I'm very grateful for the talk. And I think when labs are normal, we're not always pulling them out and saying, oh, we can go up on the, you know, the ACE or the ARB now. Oh, the K is okay. Like it wasn't, let's do it. And sometimes it tends to sit. So thank you.
Thank you all.
What am I doing?
I would really like that cardiorenal piece for our team.
Yeah, I think, you know, it might be a talk for the future, depending on what the schedule allows, but I think it's one of those things that's evolving and it's not crystal clear. It's kind of like mud, but I think it's an interesting subject that, you know, a lot of our patients dance around. So it'd be nice for us to have a little bit more information about it.
Thank you for your time and expertise.
And thanks, Mike. Thank you. And thanks to Andrea for arranging this. It was a great talk.
Yeah, thank you all.
Thank you.